So, a very good afternoon to you all. I, Dr. Swati, welcome you all to this BLK Telepeats webinar. And this month we are doing hormones to high resolution imaging, managing thyroid swelling in children. So, thyroid swelling is not uncommon in children and it requires a systematic approach to evaluation and management. To moderate today's session, we have with us Dr. Smita Ramachandran. She is Senior Consultant Pediatric and Adolescent Endocrinology at BLKMAX Center for Child Health. Welcome, Dr. Smita. Uh, we also have Dr. Alka Kumar, Senior Director, Nuclear Medicine, BLKMAX Super Specialty Hospital. Ma'am's expertise and experience in the field is very well acknowledged. Welcome, ma'am. And Dr. Akash Bansal, Consultant Intervention Radiology, BLKMAX Super Specialty Hospital. Welcome, Dr. Akash. So,
Thank you.
without further ado, over to you, Dr. Smita.
Thank you, Dr. Swati. Like Dr. Swati said, thyroid swellings are not very uncommon in children. But what we're trying to address here is not just about swellings, where all we need radiological interventions and how to go about doing it. Where do we need it? Where do we don't need it? And how to go forward. So, briefly, we know thyroid hormones are essential, especially in the first 3 years of life, because 70 to 80% of brain development happens in that time. So it's very, very crucial to diagnose early, treat them early, and also beyond the 3 year target is also because it affects the entire body in whole, the brain, the skeletal system, growth. Congenital hypothyroidism, we know, is the most preventable, one of the most preventable causes of mental retardation. So, therefore, early detection becomes even more important, and it's imperative because it's you can prevent irreversible brain damage. Other than hypothyroidism, what we always focus on hypothyroidism, hyperthyroidism is also a condition which is seen in children, and we need to know how to go about the flowchart to diagnose and manage. So, thyroid swellings can be anything. The most commonly that we see in children is Hashimoto's or Graves. Either can present with a thyroid swelling, thyroid nodules, cancers. Non-pediatric, of course, you can have more in pregnancy. Inflammation, iodine are still lower on the list. Thyroid nodules are also not very common, but can't say they're not seen in children. So let's start with the first case, which is something that we all see, but there are places where we get stumped as to how to proceed. So these are simply laid out guidelines for that. We have a term 3 kg, single child, normal vaginal delivery, hemodynamically stable. There isn't any antenatal, perinatal significant history. The mother is not on any medications. So the dried blood sample of the thyroid sent on day 1 was 24. So what we do is when we do a 24, we repeated the sample again on day 7, which rose to 45. And the free T4, the free thyroxine hormone level was 1.109 nanogram per deciliter. So this is typically what we see how a child with congenital hypothyroidism is picked up. Again, like I said, it is the most easily preventable cause of mental retardation. The problem is we don't have a universal newborn screening program in India to pick up hypothyroidism when it affects almost 1 in 1,000 newborns. So this needs to be a key message from this presentation for all of us is that we need to pick up congenital hypothyroidism. We should not be even missing one of these. So, what happens after birth? What is important is the tricky part is picking up the values on which to treat, when to intervene. So, normally, what we see is after birth, there is a rise in TSH levels due to the stress of delivery, the cooling process of the body, and the TSH can rise within 30 minutes of birth. This is also followed by a rise of a 2 to 6 fold rise of T4 within the first 24 hours. This is a stage of physiological hypothyroidism. However, what we need to remember is this TSH surge is not sustained. It's short lived and it declines to about normal by 72 hours. So, either the sample should be taken before 30 minutes or after 72 hours. In case we've taken a sample anywhere in between and you get a high value, more than 20, recall, so we don't miss any. So the idea is ideally before 30 minutes or after 72 hours, in case there's a chance you're missing the baby, they get discharged. Take a sample. If the value is on a higher value, more than 20, recall. So, what is the etiology for congenital hypothyroidism. So the most common is agenesis or dysgenesis of the thyroid gland, followed by enzymatic defects. So now, over the years, the demographic changes are seen where enzyme defects are picked up more and more. So earlier it used to be 80-20% where we used to say about agenesis and dyshomogenesis. However, now the incidence of dyshomogenesis is rising in the Asian population. Of course, in endemic regions, iodine deficiency, the intake of any goitrogens of mother, central causes where this pituitary causes, where the entire panhypopituitarism is there, as a result of which hypothyroidism can manifest. So this is the ISPE guidelines that we follow, the Indian Society of Pediatric. Also, similar guidelines by the Endocrine Society, European guidelines also, that the TSH value for cutoff for recall, where you will recall the child for a second value or where you plan to treat, is 20. So any child with a TSH more than 20, less than 2 weeks of life, or more than 10 at more than 2 weeks of life is a recall value. Any child who has a TSH more than 80 is where we do immediately recall the child within 72 hours, start the treatment. Between 20 to 40 is when you can recall the child within a week's time and repeat the sample and see. So the screening is only for TSH. The recall sample is both TSH and free T4. What do you do after recall? If after recall, if the child is less than 2 weeks, the TSH is less than 20, it's normal. If after 2 weeks, the TSH is more than 10, we say it's persistently elevated, we treat. Any child who comes to you with a TSH of 80, you will call the child, take a sample, start the treatment. Why? The chance that this is a physiological surge is unlikely beyond 80. So, if there's a high chance, this is something of a permanent hypothyroidism, and we can titrate the dose there onwards. The only other condition where, irrespective of the higher values of TSH, we start treatment is when we have a FT4, which is free T4 less than 1.1 nanogram per deciliter. So, irrespective of that, you treat, follow up the child for evaluation, and evaluate for radiological investigations side by side. So you do not wait for the radiological interventions to start your treatment. So you start the thyroxine replacement therapy and you advise the radiological interventions. So when to screen? All newborns, irrespective of gestation, should be screened for hypothyroidism. Ideally, after the 72 hours of life in all term babies. Sick newborns can have a variable presentation, so should be screened at least 7 days of age. If not, a second screen should be done at 4 weeks. But if in a sick child, but if the child is discharged early, call them back before at least at 2 weeks and screen the child. So then comes what happens with radio imaging. What does the guideline say? What are the options we have? So ultrasonography and scintigraphy are both advised. It is required for etiological diagnosis, to know prognostication, and also to identify and give the parents an idea as to what are the concerns, why the child needs it, and also to tell them the importance of the giving them medicine so that they don't miss the doses. The guidelines, international and national guidelines, both recommend that we should use both ultrasonography and scintigraphy. However, if we've not done or it's not available due to any reason, start the medicine. Do not wait for the radiological interventions to start medication. So this is a scan that we did. Alka ma'am, I would request you to explain this. I think you would do it a bit better than we would, as what happens when we take a child for scintigraphy.
So this is a newborn child. I think he was 2 weeks old who came for a thyroid scintigraphy. Now, in children, we try to use technetium agent because the half-life is short. So we avoid a I-131 scan. I-123 is not available in this country. So this is a baby. Now this spot you see here is the position of the thyroid gland, which is near the base of tongue. So it's a lingual thyroid, and the dark spot you see just below it is the marker on the chin, and the one below it is the suprasternal notch. So this we gave the diagnosis as a lingual thyroid. So thyroid is not in its regular normal anatomical position, it is ectopically placed. So this can be dead in another newborn baby who had very high TSH and who had come to rule out a thyroid agenesis. And in this baby also we've done a technetium scan, and in this we cannot visualize the thyroid gland at all. So we reported it as agenesis of the thyroid gland.
So that's the importance of this scintigraphy, because you will identify whether you have an ectopic gland, you have a agenesis where there's no gland, there's no uptake, or there is an increased uptake where there's probably some dyshomogenesis in certain conditions. Dyshomogenesis can present in both low uptake or high uptake depending upon the mutation or the lesion. So this is where I said we need to start evaluation, start the replacement therapy for babies. Again, I'm repeating, TSH more than 20, less than 2 weeks, TSH more than 10, beyond 2 weeks, you need to treat this child. Irrespective of your diagnosis, if you've got your radiological diagnosis, if it's still ultrasound and scintigraphy are normal, if these values are persisting, you need to treat, because even transient hypothyroidism, if persisting for a long time, can adversely affect the child. So what you do is you start the medication, you monitor the baby and taper it off if the dose is not required. You do not leave them without treating if your radiological evaluation is for a normal thyroid also. So the standard dosing is 10 to 15 micrograms per kg per day should be initiated. Higher the dose for more severe the congenital hypothyroidism, or very low T4 levels, also you start with a higher dose. What is important in children? This is very important, for very different from adults, is A, you do not give anything empty stomach. There is no concept of fasting or empty stomach in newborns. What it needs to be done is the tablet, it's the same tablet as the adults. It comes in 12.5, 25, 50, 70, 62.5, and so on. You will give it at the same time every day with breast milk, right? So here, what is important is the consistency of timing. It has to be given every day at the same time. So that is more or less about congenital hypothyroidism. The most important factor here being no child should be missed. Screening should not be missed in any institutional delivery for a child with congenital hypothyroidism, because it is imperative to pick them up, because you can correct them. Their mental acumen will be normal if picked up right and treated on time. When they come late to you, there is a lot of developmental delays, there's a lot of delay in their intellect, which the child may or may not catch up, depends upon how prolonged the congenital hypothyroidism has persisted. So now let's go to the next question, case, which a lot of us face and we don't know how to go about with. A lot of times, at least with me, I get confused. These are two of the patients who've come to me with swelling, thyroid ki swelling hai. So with parents, anything in and around the neck is thyroid. So these two cases came to me. So like I said, thyroid nodules are usually more in adults. It's rarer in the pediatric population, about affecting only 1 to 2%. But you can have non-thyroid diseases also in the same region. It can be an abscess. It can be a vascular malformation. It can be lymphatic malformations. It can be an ectopic thymus or a thyroglosal cyst. So thyroid nodules in itself can have multiple presentation, from a solitary nodule to a multinodule goiter to autoimmune. Both Hashimoto's or Graves can present with a nodule. So, Dr. Akash, we know the first we work up is we do a physical examination, we do a thyroid function test. And then, of course, we always advise a sonography to find out what are we dealing with. FNAC should be ideally only done once our radiologist has had a look at it and to tell us where we need it. So thyroid function test will only indicate you if you have a hyperfunctioning or a underfunctioning thyroid. So TSH, we do it to see if it is hypothyroidism. T4, when we suspect hyperthyroidism. Again, anti-TPO antibodies is also when we're suspecting hyper or hypothyroidism. Calcitonin and TGs are usually when we're suspecting, they are used as cancer markers. So, Dr. Akash, when these kind of patients come to you, I'm sure you see when we send a lot of these neck swellings,
Yes.
query thyroid swellings. How do you go about it?
Ma'am, the initial test, as you said, is ultrasonography. So, neck swelling can present in a variety of ways. These are all thyroid lesions. Apologies if my images, most of them images have needles, because I take the images during my procedures. So the first image is a large thyroid nodule around 3 into 4 centimeter with it's ecogenic and it has multiple cystic areas. So on ultrasonography, we give thyroid scoring, thyroids from 1 to 6, where 1 is normal finding and 6 is FNAC proven malignancy, and thyroid 5 is the as the score keeps on increasing, the chances of malignancy increases. So the first image was given as thyroid 2, and on FNAC it came out to be a benign Bethesda category 2 benign thyroid nodule. And the second lesion was also given as thyroid 2. It is also similar in appearance, ecogenic with the central cystic area. However, on FNAC, it was found to be chronic lymphocytic thyroiditis in a child. The third image is slightly hypoechoic, and on ultrasound images, we can categorize as a thyroids 3 or 4. And however, on ultrasound on FNAC, it was proven to be atypia of undetermined significance. So it was a pathologic rating is also from 2 to 5, and it was given as Bethesda category 3, and a repeat FNAC was advised. The fourth image, it has features of malignancy, like it is taller than wider. There is a multiple punctate foci of calcification, and so on FNAC also it proved to be a papillary thyroid carcinoma. And the last image is the same patient as the first image, and because of the large thyroid nodule causing cosmetic symptoms as well as tracheal compression, we did an thyroid ablation, microwave ablation of the thyroid nodule to reduce the size. This is another differential of next swelling in
Akash,
children.
can I just can you take a question before we go to the next? So, based on these, what are these features that you see on ultrasound? Or like sometimes we don't get a very complete, we just get hypoechoic, hyperechoic. So, what are these features which are a red flag sign that would, make aware a physician that maybe this child needs to be monitored more frequently?
So, ma'am, if the lesion is hypoechoic, and it will go more towards suspicious category. Hyperechoic lesions are generally colloid nodules, and hyperechoic lesions with central cystic areas are generally benign, and we categorize them as thyroids 2 or thyroids 3, depending on their vascularity. If the lesion is taller than wider, like in the fourth image, it is the height is more than the width, and there are multiple hypoechoic areas, and calcification also differs. If there is a single punctate dense focus of calcification, it is generally a benign finding, whereas if there are multiple tiny microcalcifications scattered throughout the lesion, it is more suspicious. And vascularity also we see on color Doppler. Malignant lesions generally are more hypervascular with more central vascularity than benign, although it is not a very strict criteria, but generally, along with the other findings of malignancy, if the vascularity is increased, we consider it to be thyroid 4 or 5 lesion. And so this is a differential of a neck swelling in children. We had this patient, a 4-year-old child, who had a neck swelling. On ultrasound, ultrasound and MRI, it was found to be a vascular malformation, a slow flow vascular malformation. In the first image, we can see that there is a dense calcification, which is a phlebolith, indicating that this is a hemangioma. And on the second images, we can see the vascular channels, the abnormal vascular channels. The third image shows us the needle placement. We did a sclerotherapy for this patient. And the fourth image is after sclerotherapy, we put a 2% cetrol injection mixed with contrast and air into the vascular channels for the treatment of these kind of. So we get a lot of pediatric patients for vascular malformations. So depending on the high flow or low flow, for low flow we go for sclerotherapies, and for high flow we go for embolization, endovascular embolization. Next. So when to do sonography in any neck swelling in children, I think the sonography should be the first choice of investigation. And for otherwise diffuse or nodular goiter, any thyroid nodule, cancer survivors after radiation, genetic syndromes, and we keep a lot of patients on follow-up after thyroid surgery for any residual lesion in the thyroid bed or any cervical lymphadenopathy even after treatment. and if the patient has hyperthyroid state or subclinical hypothyroid or hypothyroid without goiter. Scintigraphy, ma'am may better be able to explain, but broadly it differentiates between functioning and non-functioning nodules. And historically, cold nodules were considered to be malignant, had a higher malignancy risk. However, they may often be benign, and incidence of malignancy ranges from about 20 to 60%. Hot nodules sometimes may be follicular adenoma and adenomatous goiter hyperplasia, chronic lymphocytic thyroiditis. Even a colloid goiter can be a hot nodule, and but generally they are not do not turn out to be carcinomas. Scintigraphy is currently performed in thyrotoxic patients with thyroid nodules and detecting ectopic thyroid tissue in children, like ma'am explained in the previous case.
Thank you, Dr. Akash. So, surgery is what is your opinion about surgery? I mean, when do you think we should refer for surgery? I mean, I know it's not your domain, but you closely interact with surgeons when there is sonographical report and when we refer. So, it's always a team, the physician, the radiologist, and the surgeon. So, when is this? When do you think is when we should be referring to a surgeon or when we should consider surgery?
And for all these suspicious ultrasound findings, like any ultrasound finding where we find that the lesion is Thyroids 4 or 5, or there are enlarged lymph nodes and an associated lesion in the thyroid, so then we immediately consult with the surgeons to at least get an FNAC done to prove whether it is suspicious or if it is benign or malignant. And sometimes the nodules are less than 1 centimeter, but still they have features of malignancy, like they are very hard, hypoechoic, and have calcifications. So every patient of thyroid with thyroid 3 and above, we generally recommend FNAC and further surgery. And thyroids 2 and 1, we keep on close follow-up. For nodule size less more than 4 centimeter and compressive symptoms, yes, surgery has been a traditional option. But now, as I showed the case, we are also doing thyroid ablations and a minimally non-invasive procedure to reduce the compressive symptoms and the cosmetic effects. And family preference, of course, if patient are not willing for surgery and it turns out to be benign, so we can keep the patient under close follow-up. And surgery, depending on whether it is a malignant lesion or a benign lesion, it can be a lobectomy plus hysterectomy or total thyroidectomy, especially if it is a bilobar disease. And surgery may be deferred in autonomous nodules, subclinical hyperthyroidism, and completion. Completion thyroidectomy, radiation, radioiodine ablation versus observation is again a clinical decision based on a lot of factors.
Right. Thank you, Dr. Akash. So I think that gave a lot of clarity because a lot of time we just have children whose parents come to you with thyroid swelling. It's more like a swelling in the neck. So other than the biochemical evaluation of the thyroid function test, what is imperative is we should always get an ultrasound of the thyroid to know whether we're dealing with a thyroid etiology or is it some non-thyroid disease. If it is a thyroid, also the findings, the TRAD scoring, like Dr. Akash said, will help us give an clear indication how closely we need to follow up this patient, or if it's a benign condition, we can follow them up once in 6 months, or whether we need to follow them more or need to rope in an oncologist. Thank you. So now let's going on to the third case. This is one of our patients currently. He's a 16-year-old boy who came to us with complaints of he was losing weight. The parents noticed a swelling in the neck, which was progressively increasing, sweating, non-specific symptoms. So when we did a biochemistry, as you see, his TSH was very, very suppressed. FT4 was high, FT3 was high, and his TSH receptor antibodies was significantly high. So biochemically, this child is presenting with hyperthyroidism and antibody positive. So he's Graves' disease. So when we get a Graves' disease, the next thing what we do is when we get antibody positive, we do a technetium scan. So this is our technetium scan, which showed an increased uptake of 11% and a grade 2 diffuse toxic goiter. So we have hyperthyroidism with Graves' disease. So the management is primarily, the first line of management is medication, it's antithyroid drugs. Then we have the option in non-resolving cases whether to do radioiodine ablation or surgery. So management of hypothyroidism is, it's a two-pronged approach. You have to suppress the biochemical parameters which are resulting in the symptom, and also give management for the symptoms in itself. So most of them have tachycardia, palpitations. So beta blockers, Lugos, iodines, or depending upon the severity, or if it's a child is in a storm, we can also consider adding glucocorticoids or steroids to it. The anti-thyroid medications that we use are carbimazole, methimazole, or propylthiouracil. Carbimazole, methimazole are the ones where we use more commonly because of more side effects of propylthiouracil. How does it work? It inhibits the thyroid hormone synthesis by interfering with the iodine incorporation, prevents the deiodination of T4 to T3, that is only by PTU. What is tricky about starting the doses is you have to keep titrating it. With this child, we went backward, forward with the dosing, uh, titrating it against the side effects, titrating against with hyperthyroidism, which can convert to hypothyroidism when the dosing is extra. When you reduce the doses, they again jump to hypothyroidism. So you sometimes you need to block and replace regime is also required. What happens in block and replace regime is it's not commonly done, but in tricky cases like this one, we continued him on his carbimazole and the low dose, which required beyond which there was not a jump in hyperthyroidism, but it led to clinical hypothyroidism, and he was not going into remission. So we blocked with an carbimazole, and we added thyroxine to be able to continue giving carbimazole for the duration of remission. What needs to be monitored with carbimazole is the side effects. So sometimes arthralgia, skin rashes are minor side effects. GI symptoms can be minor. What we need to is we need to monitor CBCs constantly to see the effect on the white blood counts. So what happened in our case was, despite block and treat, this child was continued on oral medications. He was doing well, but even after 4 years, there is no remission. Ma'am, how do we go forward from here, ma'am?
Okay, the first thing is that, normally we don't give pneumocozole for more than a year because it can cause the gland to become nodular. And then when the child or the adult comes to us for radioiodine therapy, we have to give a much higher dose. So as a routine, we don't give any anti-thyroid drug for more than a year. If in within a year the child doesn't become hypothyroidism, he should be referred for either surgery or radioiodine therapy.
So in this case, this is a child in school
Let's
whose
go to the
parents
next
were
slide.
not, his parents were not prepared for any interventions, and remissions in hyperthyroidism in Graves can sometimes happen over a period of 18 to 24 months also. So, ma'am, that's the reason we continued
Yeah, but
antibiotics.
definitely not for 4 years. That is a little far stretched. Anyway, I'll talk about the radioiodine therapy. Can you, yeah. So when we talk about radical cure, one is of course the radioiodine therapy, and second is the surgery. So there are some inclusion criteria for radioiodine therapy. Is one that the child has already been on antithyroid medication and is not achieving remission, like you said, within a year and a half or 2 years. Secondly, there are severe side effects of antithyroid drugs like granulocytosis, or sometimes children develop very bad rash. Third is that the parents are not willing for surgery. And of course, in younger age group, less than 5 years, because it's a growing age, it can cause developmental delays. So when the child comes to us, the iodine which we give is either you can give a fixed or calculated dose. Normally, we calculate the weight of the gland by the ultrasound. The dose is 100 to 200 microcurie per gram of thyroid tissue. Can we go to the next slide? So, before the child comes, okay, let me just talk about this. That when we give radioiodine therapy, the side effects which could be is, of course, there could be swelling in the neck, further swelling in the neck. There will be some nausea. There will be some taste abnormality because it goes into the salivary glands. There could be some inflammation of the glands, and there could be some radiation-induced gastritis. If the child has already got severe ophthalmopathy and we need to give radioiodine therapy, then we give it under the cover of steroids. Of course, these risks are there. like genetic damage, thyroid neoplasms, and non-thyroid cancers. Though I haven't seen any of these in my experience, but for educational purposes, these can be there because we're giving radiation. Next slide. So, like I said, antithyroid drugs for more than 2 years, patient should come to us. Allergy to any antithyroid drugs, they should come to us. Any liver dysfunction, they should come to us. So when the child comes to us, we make the child be off antithyroid drugs for at least 72 hours. Thyroid change, then we avoid giving radioiodine therapy because there can be a chance of a thyroid storm. So we give antithyroid drugs for some more time till the TFT is within 3 times of the normal range. Patient comes fasting. Dose, like I told you, is 0.15 to zero point 0.2 millicurie per gram of thyroid tissue. It can be given either in a capsule or a liquid form. And we normally don't give iodine to children who are less than 5 to 10 years. Again, either with severe exophthalmos or if the TFT is more than 4 times the normal range.
So, ma'am, a few questions here is when
Hmm,
we give radioiodine and treatment,
hmm,
how long? A lot of parents, it's radiation.
hmm.
Yeah, are there any immediate precautions that we need to take? Does the child have radioactivity? Does he need to be isolated?
No, no. First of all, no isolation is needed when we're giving treatment for hyperthyroidism, unless they have small babies in the house which are less than 1 year old. So the elder one needs to stay away maybe for 72 or to 96 hours. But otherwise, there is no precaution because the dose is within the public limits. So no precaution as far as isolation. There is no need for isolation. Secondly, because sometimes they develop a lot of swelling and salivary gland, pain in the salivary glands, we normally advise them to have a lot of sweet lemon candy to keep chewing on it, or they can have chewing gum so that the salivary glands keep working and the pain in the glands goes away. Otherwise, there is no precaution. It's an OPD procedure. The child comes, drinks it, and goes home, and no isolation, no precaution. Not for this kind of dose.
Ma'am, what
Isolation is only when we give a much higher dose and when we admit in the ward and give it, not for this.
OPD? Okay, not for the OPD based treatment.
No,
You don't
no,
need
no,
it. Ma'am,
no.
the second question is there what is the incidence of a repeat dose of this? Is it 100% successful that after so many, I mean, after how many days of a radioactive iodine therapy do you
So
expect?
normally, yeah, yeah. Okay, so normally the remission rate is almost 95% on the single dose. Sometimes, like 5 to 10% children may need a second dose, but that second dose is also given after 6 months of the first dose. You don't give it immediately. You have to wait for 6 months, see, and then repeat it needed. But 95% of the children are cured with one dose.
Understood. And ma'am, within how much time can we expect to see a fall in the thyroid functions?
Well, it takes at least 3 to 4 weeks. And the goal of this treatment is to make the child hypothyroid. We're not aiming for euthyroid. We are aiming for hypothyroidism because that is easily controlled by replacement therapy, like you said. So at least 3 weeks we need before the values of the abnormal T3 and T4 start falling. It takes time, at least 3 weeks minimum.
Uh, Ma'am, any other additional requirement the child needs prior to planning a radioactive iodine therapy?
Nothing, nothing. We just stop the antithyroid drugs for 3 days. Child comes fasting in the morning. And before that, we just repeat the TFT to make sure it's not too high so that we don't want to risk a thyroid storm. And the baby comes or the child comes and drinks the medicine and goes home.
Yes,
It hardly takes 10 minutes for the whole story.
understood. And ma'am, when do you think is when we should refer for surgery? Again, not completely your domain, but I think you would be best suited to answer
Surgery,
this.
if supposing if the gland is very large,
Hmm.
it's a huge multinodular goiter because, they have not taken proper treatment. Then it is in a multinodular toxic goiter, even in a child, it is difficult to get remission with radioiodine. So those cases must be sent for surgery. Second is if there is severe exophthalmos, which is not responding to ATD or to steroids, in that case, you send the child for surgery. And thirdly, if you know the parents are not willing, they think मेरे बच्चे को कुछ और cancer हो जाएगा, then there is no other option. Then you send for surgery. But it is rarely done these days because radioiodine, it's a non-invasive procedure. Most children, if the parents are counseled well, they do go for it.
Correct. And it's an OPD procedure.
Yeah.
No admissions required for it also.
Nothing.
Right. So this is from the Pediatric Endocrine Society, where they've flowchart, which is going to be of helpful to us, is of how to manage and what are the treatment protocols for Graves' disease. So, like you see, any child who's less than 5 years, long-term replacement therapy, so you consider antithyroid medications for smaller children. Older children, who are more than 5 years, like ma'am said, not responding to treatment beyond 2 years of age, unwilling for surgery, not very large thyroid glands, we can consider radioactive iodine. And very large multinodular goiters over eggs of thalamus, like ma'am said, again, thyroidectomy, partial or total, would be the way to go forward. I think with that we can wrap up the session for today. We've had very, very interesting three cases. Great inputs by Dr. Alka ma'am and Dr. Akash. Dr. Swati, that would be it. I thank you all for joining us today. I hope this has been informative for all of us.
Thank you, Smita, for having us here. We really enjoyed this.
Thank you, ma'am.
Thank you, Dr. Akash.
Bye.
Yeah, so Dr. Smita, would you like to, while I check the chat box for questions, would you like to just to re-emphasize some key points and pointers, take-home points for the pediatricians for their
Yes.
routine practice? Which
So, first and foremost, what I we keep reiterating, all of us as endocrinologists and pediatricians, is every newborn should be screened for hypothyroidism, irrespective of the maternal status of thyroid disease or family history of hypothyroidism. It is one of the most preventable causes of mental retardation. All it takes is one pill to continue for a baby to have normal intelligence and normal milestones. So there should be no excuse of any institutional baby not being screened for hypothyroidism. Uh, we should not, in a case of congenital hypothyroidism, wait for ultrasound or scintigraphy to start your treatment. Once starting the thyroxine replacement, the scintigraphy can be still done within a week to 10 days of starting the medicine. The ultrasonography can be done up to 3 weeks of starting the medication. So, what is important is you start the medication and follow the baby up serially. In case sometimes which happens is if baby comes to you when it's beyond that period of 3 to 4 weeks or even more and on thyroxine replacement, do not stop the medicine till 3 years of age to test for scintigraphy or ultrasonography. Once the baby is 3 years of age, more than 80% of brain development happened, is when we can try to taper the dose and evaluate for the cause, which is either a sonography or a scintigraphy, not before that. Second thing is thyroid swellings, any kind of thyroid swelling, and ultrasound is a basic. A lot of features of the ultrasound, primarily being diffused calcifications, hypoechoic lesions, irregular margins, length more than width. These are all red flag signs on a thyroid ultrasound that if you get. So most of the centers now give a Tirad scoring, but sometimes you don't get a Tirad. Also, I've had a lot of times sonography reports without a Tirad score. The Tirad 1 or 2 is usually benign. But if you have any of these signs, these are babies where you should consider an FNAC to make a diagnosis. And if the FNAC is suspected, rope in an oncologist and do the necessary. Even if the child doesn't agree for an FNAC, these children should be closely monitored for follow-up ultrasounds. Thyroglossal cysts don't need to be treated per se, it's a cosmetic issue. So the first picture that we had was a thyroglossal cyst. So it's a cosmetic issue. Sometimes large goiters which are not functional, it being a cosmetic issue has been a reason for surgery also, which is acceptable because it is the decision of the parent and the child. because a big swelling in the neck can be a peer pressure thing for the children. Coming to Graves, the take home with Graves is it can be challenging to control hyperthyroidism versus managing hypothyroidism in the same child. So, while we're suppressing it, the suppressions need to be sometimes longer. We have case reports of where, in this case, this is a child who was in 8th or 9th or something, who was unwilling for any kind of intervention without any side effects. He's on low dose of neomercazole with normal LFTs and normal CDC, who are now willing to go beyond treatment. So in some case to case basis, long term therapy with the anti-thyroid medications have been reported in literature also. But again, this has to be, the parents have to be explained that it takes usually 18 to 24 months for the thyroid receptor antibodies to be removed from the system. So till then you suppress it. So once that goes down is when the child goes into remission. If the TRAB antibodies continue to be high, the chances of the child going into remission is less.
So, and how common are thyroid malignancies in children?
So thyroid malignancies are not very, very common in children. They're quite rare. In fact, papillary thyroid carcinoma is of the malignancies. It is what's seen more in children. In fact, thyroid nodules in itself is less in children. You only get 1 to 2%. But when you do it, they need to be followed up. So scintigraphy helps there to see whether it's a hot nodule or a cold nodule, because ectopic hot nodules will be also a source of your hyperthyroidism, where your antithyroid medication may not work because it will not suppress a homogeneous hyperfunctioning gland will respond more to an antithyroid medication than a single nodule which is working. So again, ultrasound, any swellings, your other than your thyroid function test, which will tell you whether you have a hyperfunctioning or a hypofunctioning. Your sonography will help you identify the lesion and also in turn to prognosticate as to how to go forward, whether it's just medicines which is required or do we need to look at surgical interventions.
Okay. And long term, are there any risk of malignancies with the antithyroid drugs?
Anti-thyroid drugs per se do not have, treatment for, risk for malignancies. Having said so, it is very easier both for the child biochemically and physically to manage a child with hypothyroidism. So when we give a radioactive ablation, like ma'am said, she's never had an experience. In the literature says it's low risk. However, this is something you have to mention to the parents, even if the risk is low from a medical point of view, a medical legal point of view. Secondly, radioactive ablation or thyroidectomy will lead to hypothyroidism. So, however, hypothyroidism is a much easier condition to manage in relation to hyperthyroidism. It does not become life threatening at any point of time. The only two conditions in life where hypothyroidism needs to be managed very strictly is the first 3 years of life for brain development and during pregnancy because of the fetal implications also. Other than that, managing a hypothyroidism, even with little fluctuations up and down, will not cause significant morbidity or mortality to the child.
Okay. So we do not have any questions in the chat box, but any of the attendees, if they want to ask questions, they can unmute themselves. Meanwhile, I would request Alka ma'am if you want to add any other inputs or share your experience. Is ma'am there? Yes, she has left already. Okay. So in that case, we have come to the closure of this session. Thank you, Dr. Smita, for such an insightful and a very practical presentation. I also like to thank our panelists for sharing their expertise with such clarity, which highlights that a multidisciplinary and a systematic approach is required for managing such complex patients. So the recording of this session will soon be available at blkpediatricpractice.com YouTube channel. And next month, we will be back with another interesting session, the details of which will be communicated. Thank you so much.
Thank you so
Thank you
much.
all the attendees. Thank you so much.